All right, welcome everyone to Tuesday's topic. And today we're going to talk about the brain-heart connection and really the discussion of whether or not this is adrenergic activation. And so it's really important to appreciate that this is actually a discussion that's really going to be about the types of patients that create a lot of confusion for us when they come through the ED and what our relationship is with these patients. So first and foremost, I'm showing you an EKG. I'm asking you what you think about this EKG. So for those of you who are somewhat EKG friendly, you're going to kind of give a global look to this EKG, and you will notice that you have ST segment, what you believe to be ST segment elevation, V2, probably V1, V2, V3, V4, V5, and some in V6. So it looks to us like we have a full anterior wall MI. And indeed, that's what our computer is going to say. So on this patient, we're going to take a quick look at our patient. And this patient is an out-of-hospital cardiac arrest. 44-year-old, history of left MCA aneurysm, left frontal craniectomy, clipped on 12/10/21. Today is January, when the day the patient presented, January 7th, 2023. Now, this patient has a history of hypertension, not so well controlled, and a history of stress cardiomyopathy. Probably better known to you, stress cardiomyopathy. You might hear about it as broken heart syndrome or Takotsubo disease. All the same thing as stress-induced cardiomyopathy. Has some other problems. Has a cardiac arrest at home. Husband initiated CPR as instructed by 911. EMS shock ×1. Patient had return of spontaneous circulation. So first medical contact is 1703. This is a Grady ambulance from my hospital, Grady. They actually look at the EKG. They call a STEMI alert. So the ambulance crew has activated a STEMI. 17 minutes after arrival on site, activated a STEMI. The patient is admitted in through the ECC, is taken into a particular room that we call the CPR room because he's a cardiac arrest. Remember, he's had return of spontaneous circulation, and he has very significant tachypnea, has mild to moderate tachycardia, and I don't think this blood pressure is right, but this is what's documented by the ERNRs, 145/130. I couldn't find anything to validate that. Patient was intubated to protect her airway, and the cardiologist takes a look at the EKG, the same EKG that we looked at, and cardiologist canceled the STEMI alert. Now, we're going to look at this and say, oh, that EKG looked pretty significant. We had a lot of ST segment elevation. And by the way, HS troponin is 232. Just remember, HS troponin is 1,000 times the normal troponin. It's just a matter of what you're measuring it in. So historically, that troponin would have been 0.023, but times 1,000, the troponin is 232. But very important to note that the patient has a GCS of 3. She's intubated for her airway protection. She's hypotensive on arrival. We don't see that here, but was started on norepinephrine, and the STEMI alert was called before the patient arrived, but it was canceled after repeating the EKG and discussing with cardiology. So ED doc, EMS, all the ED nurses all believe this patient is having the STEMI, and the cardiologist says, it's not a STEMI. It's not a STEMI. Okay, so we're going to take a look at some of the things and the qualifiers that actually validate for us that that's not a STEMI. But before we do that, we just want to remind ourselves about the integral component of heart-brain crosstalk, meaning that the heart and the brain have very significant interactions that affect them both. So really important to appreciate that neural control of cardiovascular function. So in the cerebral cortex, the emotional response and emotional factors, input from the cortex that's mediated through the hypothalamus that actually promotes cardiac acceleration and can also promote cardiac inhibition. But in this case, it will typically be cardiac acceleration. So what we actually see are very significant systemic factors, most importantly because of sympathetic stimulation. Now, something I'm going to mention to you here, which is vitally important for us to remember, is that this heart-brain crosstalk in the presence of subarachnoid hemorrhage in the presence of intracerebral hemorrhage, in the presence of extreme emotional disturbance and stress, ends up with a physiologic stress response that presents itself to us as tachycardia, tachypnea, ST segment elevation, and elevated troponin. So you know what the only clarity here is? The story. The story is incredibly important. So what we're going to see with these individuals, very specific to the stroke and to the site of the stroke, is that oftentimes with the lesion, and particularly with subarachnoid hemorrhage, that's a really important one. Remember, that happens in that little circle of Willis, typically in either the anterior division of that perimeter, the circle of Willis, or the posterior division, and that interferes with the autonomic network. Now, patients who already have heart disease, older patients, women post-menopause, anybody with a cardiovascular risk factor who's actually had stress cardiomyopathy before, those patients are really significantly at risk. And then they have an intracerebral hemorrhage or a subarachnoid hemorrhage or severe, profound emotional response. And what you're going to see is this stroke heart syndrome, that crosstalk of the heart and the brain. You're going to see an elevation cardiac biomarker. So that's going to be in your HS troponin or your point of care, whatever it is you're doing. Hopefully you're all doing HS troponin, but it's okay if you're doing point of care or you're just doing standard lab troponin. It's always important to remember HS identifies patients who you might miss with standard troponin, and that's why we do it. But very, very importantly, we can see that our patients actually will have a significant impairment of their left ventricular function. Now, that's really important, guys, because one of the things we think about when we're looking at patients and trying to identify, are they having a STEMI? We're looking at the EKG. We're looking at your troponins. You have EKG changes, most particularly ST segment, but also T wave, appearance of U wave, and some other things that we're going to look at as well. An increase in their cardiac biomarkers. So, okay, that sounds like a STEMI. It tastes like a STEMI. And if you do an echocardiogram, you're going to see LV dysfunction. Now, one of the important perspectives here is that the EKG changes are short-term. They go away. If this is an SAH or an intracerebral hemorrhage, or if it's stress-induced cardiomyopathy or neurogenic stress cardiomyopathy like Takotsubo disease, you might see significant ST segment changes, but those will resolve typically in 2 to 4 hours. What won't resolve necessarily for a period of time, and it may take a fair amount of time, is the echo-evaluated left ventricular dysfunction. So really, really, really important to us when we're thinking about our patients and how we're evaluating this. They can often have cardiac arrhythmias like VTAC and VFib. Also, these patients frequently, subarachnoid hemorrhage patients can frequently have their subarachnoid hemorrhage at home. Nobody has identified that they lost consciousness or that they said, I've got the worst headache I ever have in my life, and then they're out of consciousness. So if somebody hasn't identified that at home, when they actually go into cardiac arrest, the cause of that cardiac arrest could be a subarachnoid hemorrhage. So this is quite important because now we're talking about a patient who is unconscious in cardiac arrest with STEMI, with a biomarker elevation in their troponin, and with left ventricular dysfunction on an echocardiogram, and we might not have the story because the story is going to be really important. There's a couple of other identifiers that are going to help us as well, but the story is really, really important. Now, frequently, these patients are going to be misdiagnosed. They're going to be diagnosed as having a STEMI. They might go to the cath lab, but what they've actually had is a subarachnoid hemorrhage, which is evolving while they're in the cath lab, and they're getting anticoagulation and antiplatelets. They're getting Plavix. They're getting heparin, which is going to exacerbate their bleeding if we don't have a lot of vigilance and a lot of evaluation of these patients early on. So obviously, that's going to affect their outcome. It certainly puts them at risk for poor functional outcome. It also puts them at risk for sudden cardiac death, of course, and it puts them at risk for problems associated with myocardial function. So really, really, really important. This beautiful case report in the Journal of West Emergency Medicine was a very significant evaluation and discussion. I'm so sorry, I just need to. Okay, it's just, sorry, somebody is texting me from my hospital asking questions. Okay, good. So when we look at this and we say, sudden cardiac arrest with a non-shockable rhythm. Non-shockable rhythm in the settings of sudden cardiac arrest should always, of course, as we know, always make us think of non-cardiac etiology, like pulmonary embolism, but also subarachnoid hemorrhage or intracranial processes. So if we have patients who come to us in the ED with non-shockable rhythms, meaning it's not VTAC and it's not VF, it's a systole, or it's PEA, usually it's going to be a systole, and then those patients achieve ROSC after CPR and medication, we should always consider the possibility that they've had a subarachnoid hemorrhage. So that's a really important key and clue. And by the way, in my discussion with ED doctors and cardiologists, this is really one of the most confounding presentations that we think about when we're trying to evaluate patients. Okay, so here's our first patient. So we looked at an EKG before. Now we're going to start looking at a couple of patients. Here's our patient. Is this a STEMI? So as you look at this, you may or may not be very well experienced in looking at STEMI. But of course, this patient's having some dysrhythmia. But if we look at the non-dysrhythmic state, we can see our patient's got ST segment elevation lead 1, ST segment elevation in AVL, and also in V2, which is a little bit unusual. We've got some ST segment depression in other leads. We have ST segment depression in AVF. We have ST segment depression in lead 3 and in lead 2. So it looks like they're having a lateral wall infarct with inferior reciprocal changes. Very, very important. So they called the STEMI alert after the EKG, but actually there was concern that in fact, the patient may have had a subarachnoid hemorrhage, and that was based on the fact that the patient had complained of having the worst headache of their life. So immediately taken a CT for a head CT, and it showed a massive bleed. So this is our patient 45 minutes later, no cardiac intervention, actually going to neurointervention to control the aneurysm, which of course we've got to do, and we've got to do quickly and easily in order to evaluate our patients and to evaluate them effectively. Okay, so easily missed. Subarachnoid hemorrhage is easily missed. Severe headache is not present in a quarter of the patients who present with a subarachnoid hemorrhage. They may not have a sudden severe headache, so you've lost that as part of their clinical presentation. 1 in 10 with sudden headache who present in the emergency department, subarachnoid hemorrhage is the cause. 1 in 10 patients with sudden severe headache. But 20 to 50% of patients on first presentation, what we can miss with those presentations is what's known as the neurogenic stunned myocardium. That results directly from the subarachnoid hemorrhage, from a high degree of catecholamine output, from a release of free ionized calcium, and it occurs in about 30% of patients with subarachnoid hemorrhage. Okay, that's a third of patients who present with subarachnoid hemorrhage may actually have a neurogenic stunned myocardium. What that means is they look like they're having a STEMI, and when you do an echo, they are hypokinetic or akinetic, which always leads us to think that the patient has myocardial functional loss. So most of these patients are going to present with what appears to be primary chest pain, ST segment elevation on their EKG, elevated biomarkers, and left ventricular dysfunction. So again, the story is important. are there neurologic changes on a neurologic assessment? So most of the time we're getting patients that we're looking at with a STEMI. The EMS has said there was a cardiac arrest. We've had return of spontaneous circulation. Now it looks like they've got a STEMI. They come into the ED. We're doing our STEMI work on that patient. And we may actually miss that they've had a subarachnoid hemorrhage. But the other side of that coin is true as well. So quite concerning to us, obviously, since we're always trying to do the right thing for our patient. It's really concerning. So this is a lovely graphic that just discusses with ischemic brain injury that you've got functional or structural alteration of the central autonomic network. So you've got ischemic brain injury, you may have cerebral edema, you have an increased ICP, you have a subarachnoid hemorrhage or an intracerebral bleed, all increasing your ICP, putting some pressure down on the central autonomic network, which then activates the sympathetic nervous system, and you end up with what we call a catecholamine storm. So sometimes you'll hear your colleagues or your preceptors or others say, oh, the patient's having neurostorming. Well, neurostorming means they're having a catecholamine storm, up to 30 times release of catecholamine. That 30-time release of catecholamine is going to actually cause electrical instability and arrhythmogenesis. It's also going to cause what we refer to as this release of calcium. Remember that the calcium is released and that increases the calcium influx into the cell. That causes really a contraction of the ventricle, which means the patient now has diastolic dysfunction. So the ventricle is contracted, so you're going to have venous engorgement, further increasing your ICP. This is also called contraction band necrosis. So now my filling capability of my ventricle is limited, which means further that the stroke volume is limited. It's going to create very significant metabolic stress and oxidative stress, which then is going to cause microvascular dysfunction that further affects the myocardium, and endothelial dysfunction, all of which will end up in what we call a type 2 myocardial infarction. It can end up in a type 2 myocardial infarction, which is a supply demand and is primarily a demand-based ischemia. So you can see kind of this whole cascade and waterfall event that occurs when you have neurologic injury. And in particular, we see it with aneurysm rupture. Now, remember, the aneurysm typically is in the anterior or posterior division of the circle of Willis, putting blood into that subarachnoid space that actually causes issues with the blood-brain barrier. It frees all this ionized calcium, which that free ionized calcium causes cerebral vasospasm, which further exacerbates the cerebral ischemia. And we see multiple effects that occur in the brain. This is not a neurotalk. So this multiple effects that are going to occur in the brain: seizures, increased ICP, brain tissue dysfunction and destruction. But what we're thinking about here is sympathetic and parasympathetic overactivity. And that means that you're going to have neurostorm, you're going to have change in neuroregulation of temperature, you're going to have fever, cardiac complications, neurogenic stress-induced cardiomyopathy. We're going to see that when we look at a chest x-ray or when we look at an echo, when we look at a CT of the chest. We're going to see that neurogenic stress cardiomyopathy. Very commonly, we'll have neurogenic pulmonary edema, and in addition to that, some physiologic stress hyperglycemia. And just as a side, remember, hyperglycemia is not allowed in cardiac patients or in neuro patients. So you've got to get on board really quickly to control their hyperglycemia. Now, something else that we will frequently see is, and when you look at this EKG, you might be thinking, ooh, look at that sharply spiked T wave. That looks like hyperkalemia, except we would have a very wide QRS, which we don't have here. We have this very high, sharply spiked T wave. This is known as a cerebral T wave. And it's one of the ways that we can look at our patients and try to identify, because of this visual, that we can try to identify, this is really related to hypercalcemia, try to identify that the patient may be a subarachnoid hemorrhage patient, okay? Don't forget, they may have ST segment elevation. They have these cerebral T waves. You get big peak T waves in the beginning of myocardial ischemia as well. They may also have T wave inversion. Troponin levels are up. The regional wall motion is stunned. Remember, stunned or hibernating means that you can recover. Hopefully, you will be able to recover over time. It's really difficult, even for the most experienced person, to actually differentiate. But I just would like to remind you about three little things. First of all, patients typically with spontaneous subarachnoid hemorrhage and subarachnoid hemorrhage induced myocardial dysfunction will often have what we call U waves. So if we just think about P, Q, R, S, T, U. The U wave is a secondary wave that often looks like a P wave or a second T wave that occurs. We don't have it in this patient, but we will see it in other patients as we look forward. But it's a small wave that occurs after the T wave, and it can actually be quite large. In fact, it could be up to 1/3 of that T wave. Those are the large U waves. The T waves are almost always abnormal. Either they're sharply spiked or they're inverted, but there are almost always abnormal T waves in subarachnoid hemorrhage induced stunned myocardium. And the other thing is from the beginning of the QRS to the end of the T wave, that's called the QT. That QT is corrected for the heart rate. All that means is when your heart beats faster, it looks normal, but it could be quite delayed. So you always correct for the heart rate. That's what QT corrected is. And these patients will have a long QTC. The most common changes, large U waves, T wave abnormalities, and a prolonged QTC. Very important when we're trying to differentiate. Okay, now we look at our second patient. And this patient, you can see again, wow, wow, wow. So leads 1, 2, 3, AVR, AVL, AVF, V1, 2, and 3, V4, 5, and 6. And down here, all of this are rhythm strips. So we're not really talking about the rhythm just now. We're looking here. And it would be quite likely that you would say, oh my God, look at that ST segment elevation. I've got some in V2. I've got it in V3. Depending on where you're drawing your baseline, you're going to think that this patient has significant ST segment elevation in multiple surface areas. Now, the computer reads this as a severe anterior and lateral myocardial infarction from V1 through V6, also in AVL, ST segment elevation, and some minor elevation here in lead 1. My purpose here is if you're not really great at 12-lead EKG, I would advise you to come to a 12-lead EKG course that I'm going to be offering in the fall. But I want to remind you, you're looking at what the computer said. You're on the phone calling the cardiologist. You might be activating a STEMI alert in your hospital or in your system to get this patient to the cath lab. However, it is really important for us to appreciate, that this patient has something really particular. And I'm going to tell you how incredible this is. In the last year, there's been over 60 articles that have vetted what we call the spiked helmet sign. Okay, so first and foremost, if this is neurologically induced, you should have acute neurologic findings. Now, you may not have loss of consciousness. It might just be a significant localized dysfunction that we can relate neurologically. Remember, we expect to see prolongation of the QT, but you may also have a U wave, and that U wave is a second wave that occurs after the T wave. It may actually merge into the T wave. But also what's really important is if I look at what I would have expected the baseline to be. So I'm really defining that close to the PR segment, and I'm drawing the dotted blue line across here. That's what I expect your horizontal levels to be. But then I see that I have a dip before the QRS, and I have a dip after the QRS. So connecting my dips, okay, this actually looks like what is known as a spiked helmet sign. And in almost all cases, spiked helmet sign is associated with critical non-cardiac illness and a high index for mortality and morbidity. So just recognizing this spiked helmet sign can be really beneficial when we're evaluating our patients. So let's take a quick look at that. So this is from a fantastic article about spiked helmet sign. Here's what the computer says. Your patient is having an acute lateral infarct and they have a prolonged QT interval. Okay, well, the QT interval is prolonged. But when I go back and look, I see this actually looks like a spiked helmet. Look at that in AVL, look at that in lead 1, look at that over here in V6. I have some reciprocal changes. My patient also has left ventricular hypertrophy. That makes it even harder for us to diagnose the patient well because that messes with all the diagnosis. But take a look at this. This is the spiked helmet sign. And that spiked helmet is like a Prussian helmet from the Prussian army. So imagine that spiked helmet, imagine that in your mind, and then look at that EKG and say, I can see that positive spiked helmet sign. So it's a post-QRX downslope, and that's very different than what you expect to see with your ST segment elevation. You expect to see a concave or sometimes even a convex, but what you're seeing is this full downslope below the baseline, and that's what's giving you what's known as that spiked helmet sign. And it's highly vetted in the literature for an appropriate sign for us to be thinking about when we're looking at our patients. Okay, so now let's go back to our patient that we saw from before and tell me if you can see a spiked helmet sign. Okay, so you can, of course, see a spiked helmet sign in multiple leads. It's really induced here. Here's a spiked helmet. It's a really high spike, and there's a couple of other leads. This one, not so much, but AVL, definitely, V1, V2, and it's very hard for us to identify this, V3, 4, 5, and 6, because they kind of merge into each other. But as you can see here, you definitely have a spiked helmet sign here in V6 and in V5. It's not a STEMI. Patient actually had a subarachnoid hemorrhage. And here's this EKG without any cardiac intervention about 4 hours later. Now, what's important for you to hear is that it's really hard to diagnose this by EKG, right? We hope that we have some neurologic presentation that tells us that the patient is actually at risk. That, of course, gives us good information, because if they have neurologic signs, we're going to assume that this is a hemorrhage. We're going to get the patient to the CT first, because we got to control that aneurysmic hemorrhage. We've got to control that free bleeding. We have to control the ICP that is pressing down on the autonomic center that's promoting this high level of sympathetic activity and the free ionized calcium flux. So really, really important for us to appreciate, first and foremost, we're getting to the CT scanner, if we can do so. And here's the thing to remember, those EKG changes aren't going to persist for long. They're going to go away in 2 to 4 hours. So really important to do serialization of the EKG, to be really reevaluating the patient continuously every 15 or 30 minutes, doing another EKG, getting to the CT scanner, taking a look at whether or not this is a subarachnoid hemorrhage or an intracerebral hemorrhage. But I want to remind you here, everything, quite honestly, everything. So I'm going to go back to this, this visualization. Everything here looks like a STEMI. The computer says it's a STEMI. The patient has an increase in troponin. We take an echo and we see apical ballooning and LV hypo or akinesis. Everything looks like a STEMI. It's really the context that's going to be important. And what's vitally important is to remember that the EKG signs are going to actually normalize 2 to 4, usually by 4 hours, but maybe even to 6 hours. Those EKG changes are going to normalize, but your patient may have persistent LV dysfunction. So folks say to me, well, if it's hard for the cardiologist and the neurologist to really know the difference, how am I going to know the difference? Here's what you're going to know. Your patient has failure to thrive. You're doing manipulation of your patient's blood pressure. You're trying to manage the patient. You've already made some reference to the subarachnoid hemorrhage. We've gone to the CT scanner. We're controlling the aneurysmic hemorrhage. We've doing a neurologic intervention or other types of management, and your patient has failure to thrive. You need to ask for an echocardiogram. That's what you need to do as a nurse. You need to be vigilant, because the echocardiogram is going to give you much more persistent changes. And we don't want to waste valuable time and resources, and we don't want to waste cerebral function dithering around about what this is. If we have neurologic presentation, you've got to get to the CT scanner quickly, because we're going to have to control that aneurysm and the aneurysm rupture to control the bleed in order to reduce the cardiac effects. Okay, here's our third patient. Now, taking a look at this third patient, tell me you can see, you would look at this patient and say, I would too, ST segment elevation lead 1 and an AVL. So I think that the patient is having a lateral MI. The other leads that look at the lateral wall will be V5 and V6. And in lead 1, AVL, V5, and V6, this is all positive for spiked helmet sign. This is a spiked helmet sign. It's a particular presentation of the way the ST segment looks, which tends not to be STEMI, even though it looks like a STEMI, and the patient has elevated troponin, etc. Now, this patient had a couple of other things that were important. Potassium was normal, sodium was relatively normal. Patient's glucose was really elevated, which means he's got to get on insulin right away. You can't allow that to persist. And his HS troponin is 630. That's a pretty significant elevation. So again, we're looking at this patient. Your ED doc is looking at this patient. Your hospitalist is looking at this patient. Your intensivist is looking at this patient. And everybody says, it's a STEMI. We got to activate a STEMI. We've got to get the patient at the cath lab. Okay, so the caution here is based on the presentation of the ST segment and what else the patient is presenting with in order for us to say this is indeed a STEMI. Okay, and this is our patient, right? I think 2 hours later. Okay, so really, really important to appreciate sort of this whole resolution of his ST segment elevation because he was a subarachnoid hemorrhage. And by the way, it is really hard for experienced clinicians, ED docs, hospitalists, intensivists, very challenging for clinicians to actually look at the difference between intracranial or subarachnoid hemorrhage induced ST segment changes from acute coronary syndrome. And in particular, remember, post-cardiac arrest. So again, I want to remind you, a non-primary cardiac arrest, meaning you didn't present with VT or VF at home, so we have no idea. But when we see that patient, what we hear is they had a return to spontaneous circulation really quickly and really easily. Now, that's not like a PEA arrest when you have a big pulmonary embolism. You don't have return to spontaneous circulation quickly. You have a non-shockable rhythm with return of spontaneous circulation. First thought should always be subarachnoid hemorrhage. And again, to remember how challenging this is. Now, for this patient, on day 3 of his hospitalization, nobody really looked at his echocardiogram until day 3, and he had really significant LV dysfunction, which was actually implied this persistence of cardiomyopathy. And this is called stress-induced or neurogenic stress cardiomyopathy, which means all along here during those 3 days, they were struggling to keep a patient's blood pressure up, to manage the patient. I'm going to call that failure to thrive. Your patient had failure to thrive, which really means you have to look at ventricular function. You've given volume, you're given vasopressin, and you have failure to thrive. Finally, someone does an echo, but now we're at day 3. And now at day 3, patient progresses pretty rapidly into cardiogenic shock, and he didn't survive. So this is really important for us to not to say, oh, we're going to be able to make all the diagnostic difference. We've just got to take a look at the patient. Okay, so here's another patient with a STEMI alert. This patient is going to be a little bit different. This patient actually has a right bundle branch block presentation that's also masking some ventricular hypertrophy, and really difficult for us to evaluate this patient, except for one thing. They have a prolonged QT interval, and this is new onset prolonged QT interval. Not really spiked helmet sign, although you could say you might have it a little bit here in V3 and V2. It's not really quite as significant as some of our other patients, AVL as well. Okay, so, but here's what the EKG says, the computer says. This is an abnormal EKG, probably an acute ST segment elevation from an infraoapical infarct. So inferior wall and the apex, which is pointing towards the left foot. Large anterior infarct, might be old. Patient's got a right bundle branch block, may have some other dysrhythms, some abnormality is called fascicular block, which is the 2 divisions of the left bundle. Again, beyond what we're talking about here, but really important for us to understand. I'm not saying you need to be able to evaluate this EKG, but this is what your computer is saying. but this is not a STEMI. Okay, so this is a 65-year-old who fell, was found on the floor, covered in feces. The next door neighbor who found the patient said, "Oh, I saw him this morning, a couple hours ago. He seemed like he was really okay. He obeys commands and he opens his eyes spontaneously, but he's confused with verbal stimulation. He can't really communicate well verbally, and he's quite confused. 12 EKG is obtained, and the paramedics actually transmitted to Grady, and it's interpreted by the Grady physician." Okay, so Grady physician, that's our ED physician, says activate a STEMI alert right away. Okay, now patient comes in. Patient says she's not having any chest pain, she's not having any shortness of breath, she's a cocaine user, tobacco user, she has uncontrolled hypertension, she had an AV malformation repair in 2014. Okay, ding, 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 ding-a-ling-a-ling-a-ling. I'm thinking, uh-oh, this might not be a STEMI. Looks like it might be a new STEMI because we have a new onset bundle branch block, and our computer is saying it's a STEMI, and maybe we're not so comfortable. As soon as our physician, our interventional cardiologist, looks at the EKG and looks at the patient's history, says, cancel the alert. This is not a STEMI. And the cardiac fellow now says, based on what's been said in discussion with our chief interventionalist and now our chief of cardiology, new right bundle branch block and some significant changes, but really not really seeing anything significant when I do a point of care ultrasound. Looks like the left ventricular fraction is low. The patient had a normal TTE on 922, so normal transthoracic echocardiogram. Doesn't have any chest pain, doesn't have any shortness of breath, hemodynamically stable, and no other issues, right? But point of care troponin is 0.1 and HS troponin 107. White count is elevated, BNP very mildly elevated, not very much. Lactic acid is 6. So another EKG is done. Okay, now the patient's QRS has gotten a little bit narrower and the QT has gotten a little bit shorter. Doesn't really look that much different than the first EKG, really. Not a big change. Patient, though, does indeed have an elevation, further elevation, HS troponin. So remember, it was 107. Now it's 681, 1 hour later. Okay. But patient has progressive neurologic decline. So they decide to intubate the patient and move the patient to our neurovascular intensive care unit. They're going to do some management of the bleed that they have seen on the CT of the head. But really important is to look at how long it took to actually get that patient to head CT. Okay, now what about this one? Okay, so here's another patient that you look at, and as soon as you look at the patient, you're seeing really a lot of abnormalities. They're kind of diffuse. They're not really particular. And again, I'm going to look at here, I have a spiked helmet sign. Okay, and it's really significant here in V2. Spiked helmet sign in AVL, not in lead 1, but AVL and V2. Lots of ST segment changes, but they're quite diffuse. Can't really make a good decision about what's occurring with the patient. Tachycardia looks like a STEMI, behaves like a STEMI. This is a 65-year-old found unresponsive with facial drooping and leftward gaze. Okay. Family thought she was drunk, just needed to sober up, but finally they couldn't get her to wake up. So they call EMS, and EMS comes, they see her 10:38. They make a call, they transmit the EKG, reviewed by the MD, and they actually activate a STEMI. Patient arrives into the emergency room, goes into our specialized room, our CPR room. Point of care troponin is 65, so that's 650. Lactic acid is elevated. Second EKG is done, and our interventionalist says, this is not a STEMI. This is a subarachnoid hemorrhage with ST segment changes. Now, again, he's the chief interventionalist, he's the chief of cardiology, and I think it takes a fair amount of courage to basically say, I don't think this is a STEMI. I think this is neurologic before you've even done a head CT. He's got a lot of guts. So patient goes to head CT at 12:40. So this is 2 hours after the patient has arrived, goes to CT of the head, and patient has an early subacute left MCA infarct without hemorrhagic transformation. So doesn't even have a hemorrhage, but has an increased intracranial pressure with high degree of sympathetic activation. So very important for that patient. Okay, so what matters here? The story, right? We want to rapidly identify patients who have aneurysmal subarachnoid hemorrhage. We hope that we're able to look at that neurologically and make good decisions. Remember, our number one goal is not to get the blood pressure up, but to keep the blood pressure down. So your patient may be somewhat shocky and you're thinking, well, I've got to get the blood pressure up. I'm putting them on Levophed. They've got myocardial injury. They have ST segment elevation. They have an elevation in their troponin. Oh my God, let's get that up. But what we often will see early on with that subarachnoid hemorrhage is stress cardiomyopathy, neurogenic pulmonary edema, and cerebral salt wasting. Now, I'm not here to do a neuro talk, and I'm not a neurospecialist. I'm really a cardiac person. But I want to just remind you that neurogenic pulmonary edema looks just like congestive heart failure pulmonary edema, except for one thing. It happens really quickly. The patient decompensates oxygenation from an oxygenation perspective very, very quickly. So remember, this hyperactivation of the sympathetic nervous system causes pulmonary vasoconstriction, increases pulmonary venous pressure, puts a huge load on the right heart. Systemic vasoconstriction can increase the systemic pressure, and that's going to see, we're going to see that we have decreased left ventricular compliance. Remember, we've got that diastolic dysfunction, contraction band necrosis, and other kinds of issues that are causing left ventricular dysfunction. And now we're going to be shifting our blood from the systemic circulation to the pulmonary circulation because we have pulmonary vasoconstriction and we have hypoxia. And now what you're going to see is as that blood shifts into the pulmonary vault, you're going to have a lot of leak into the interstitium. So very, very important. It's really looks like and behaves like ARDS. But what happens, and this is neurogenic pulmonary edema on one of our patients, what happens really quickly within minutes of their central nervous system insult, most cases 30 minutes or so, that they're going to have a pretty significant and abrupt decompensation in terms of respiratory failure. So remember, our very first patient, one of our first patients we talked about admitted, and the heart rate was 142 and the respiratory rate was 40. Okay, patient is profoundly hypoxic, very short of breath, may have pink frothy sputum looking just like pulmonary edema. Oh my God. So Barbara said to you, okay, he's got ST segment elevation, his troponins are bumped. He's got left ventricular dysfunction on echocardiogram, and now he has non-cardiogenic pulmonary edema, but it looks just like regular pulmonary edema. It's really confounding. And by the way, I'm not making it any easier for you because it's not easy. It's really complex. We just have to be vigilant. We have to evaluate. Something else that we might see with our patients here is cerebral salt wasting. And oh my God, further causing me confusion because it's going to look like heart failure. The patient is actually wasting a huge amount of salt at the kidney. Following the salt is the water, but they're wasting more salt than they are wasting water. So they're going to have hyponatremia, which looks like congestive heart failure. They're also going to have hypoosmolarity, which also looks like heart failure. Now, part of this, we believe, is related to that sympathetic neural output, failure of aldosterone. So if they're not releasing aldosterone or stimulating the release of aldosterone at the adrenal glands, because that's under sympathetic control. So if they're not releasing aldosterone, they're not going to reabsorb sodium. So they're going to waste lots and lots and lots of sodium in the urine. The other aspect and the other consideration is that the patient actually now may have some engorgement of the right atria and the right ventricle, which will stimulate the release of BNP, and that will decrease sodium reabsorption. So patient is wasting lots of sodium and wasting lots of water. And this is quite common, cerebral salt wasting with subarachnoid hemorrhage. Now, think about this relationship and how we're going to evaluate this. So remember, they've got they may have neurogenic pulmonary edema, they've got cerebral salt wasting, their serum sodium is low, their osmolality is low, but they're putting lots of sodium into the urine, and the urinosum is concentrated. So that's completely abnormal. Typically, the BUN is a little bit high because they're so concentrated. Because the BUN is extraordinarily high because of the relationship of blood urea and cerebral urea nitrogen and the wasting of urea. So your BUN may be elevated, and they may also have an increase in creatinine. But the way we really look at them and diagnose them is that their serum sodium is low and their plasma osm is low. They're wasting lots of salt in the urine, and their urine osm is high. So they're hypovolemic and hyponatremic, just like a heart failure patient. Now, some of you might say, well, that sounds really familiar. It sounds like it might be SIADH. Okay, well, with SIADH, your serum sodium is low, but your urine sodium isn't extraordinarily high. In DI, your serum sodium is high and your urine sodium is not high. Here, your urine sodium is low, your serum sodium is low and your urine sodium is high. This makes it very different than SIADH and diabetes insipidus, and it really does look like heart failure. If you have cerebral salt wasting, you need a mineral corticoid. That would be fludrocortisone, but also you would like to give volume, and probably you're going to have to give the patient sodium. So you got to come look at that really early on. Now, it's really important to remember with subarachnoid hemorrhage, what we want to do is protect the patient from vasospasm. We're going to do radiologic evaluation, sonographic. We're going to do a neurologic intervention. We may put you on neurologic calcium channel blockers, and we're going to manage any clinical vasospasm that you have very, very aggressively. Once we've controlled the aneurysmic rupture, we're going to get your blood pressure up. We're going to get your blood volume up. And it's going to be a really important concept in terms of subarachnoid hemorrhage. Now we're going to come to, I think, our last patient. And our last patient, some of you will have seen her before, okay? When we get a stat pack, it means an unidentified patient, we assign a stat pack name and we assign a false age that pretty much you will always know is not a real age of a patient because it's so old, right? So she's emergency U James Place, 114-year-old adult with a prior history of hypertension, admitted on June 7th in 2021. She had a witnessed VF arrest in the emergency department when she was identifying her deceased son's body. She had a return of spontaneous circulation after 20 minutes and 6 shocks. Post-rhythm shows left bundle branch block, a rate of 60. She has severe hypokinesis of the mid to base with a worsening akinesis of her lateral wall. She has a VF arrest and left bundle branch block. Very concerning that she might have a STEMI, so we're going to take her off to the cath lab. Probably have to give her a PCI. We're going to give her TTM, targeted temperature management, for her cardiac arrest. She's going off to the cath lab. Her husband gives consent. Okay. Now we've seen somebody like her before. Okay. She's got a very extreme left bundle branch block. Upright in 1, but really wide, upright in L, but really wide, upright in V5 and V6, and really wide. So she has a very significant left bundle branch block. She also has indicators that she may have left ventricular hypertrophy. So we don't know her. She came in to see, she was brought to us by the police. Police have said to her, we've got to take you to Grady. There's been an emergency. They don't tell you. So you're riding in the car, I'm sure can imagine all sorts of things, and your absolute worst nightmares come true. Your son, her son was in his 40s, but your son is dead. And we're going to show him to you. We want to make sure that you give us a positive identification. Now, she's with a social worker, chaplain, a doctor, and a nurse, and then she has a cardiac arrest. Again, this is her second EKG, so not really much change, pretty significant left bundle branch block. And some of you may know that historically, when we look at a new onset left bundle branch block, we typically would evaluate that for STEMI, or for an acute coronary syndrome. In today's world, we don't do that quite as much, but she has a VF arrest, so she's going to go off to the cath lab. I want you just to note here, she has great oxygenation, but she has pretty significant metabolic acidosis. And you can see that because her base deficit traveling the same direction as bicarb. Bicarb's down, base is down, metabolic acid is up, and a little bit of elevation in her PCO2, but her base deficit is definitely the major cause of her acidotic pH. She has some other problems as well. We're really not going to focus too much on those. Just want you to see that. So right here, she has this outlier of potassium 6.6. Almost immediate repeat is 4.6. So this was a hemolyzed sample, which I think everybody recognized. But her lactic acid is elevated. Her troponin this was not HS troponin. So this is the reason we do HS troponin, because for many patients, they're going to be at a relatively normal level, which actually may be mildly elevated when we look at it in a different way, dissolved in looking at troponin as it relates to liters rather than as it relates to milliliters. And that's all we're doing there. And you can see that her lactic acid comes relatively back to normal, and her beta natriuretic peptide hormone is quite elevated here. So 2000, 2,800, 2,900, 3,253. So she's got some significant abnormalities in her lab values when we look at her. She has the last that I'm talking about in this series, which is actually going to present the same way that a subarachnoid hemorrhage presents, because it's all physiologically related to catecholamine-induced hypercatecholaminism that occurs either because of severe emotional stress response, because of a subarachnoid hemorrhage, or an intracerebral hemorrhage. She actually has stress cardiomyopathy, neurogenic cardiomyopathy, also known as Takotsubo's disease. Takotsubo is the name of what we call an octopus trap. That's a Japanese octopus trap, which is narrow here at the base and really, really wide at the apex. So that's what you're seeing here. During systole, what you see is this is well contractile muscle, and this muscle is not contracting at all. So this is what we call, and you see it really, it's only during systolic dysfunction, this apical ballooning that you see during systolic dysfunction. So generally, this is reversible. Just like neurogenic stunned myocardium with subarachnoid hemorrhage or intracerebral hemorrhage, this is reversible. It does require intervention. It does require myocardial protection. It looks like ACS. You have LV dysfunction on echocardiogram. It's very common to see in postmenopausal women, and it's frequently triggered by a stressful event, which is why in the past we call it broken heart syndrome. So now I hear people say, oh, he has broken heart syndrome, her husband left her, or her husband just died, or her child died, and all of that could be true. But the real truth is this is not broken heart. This is neurogenic stress cardiomyopathy. And we do better to actually call it that, because that helps us to understand what we're going to need to do. Now, here's the thing. I want to make sure we all appreciate that you have about 30 times catecholamine surge when you have neurogenic stress cardiomyopathy, which is what we see with SAH, which is what we can see with intracerebral hemorrhage, and which is what we see with traditional Takotsubo or broken heart syndrome. It is a neurologically mediated from sympathetic activation, free ionized calcium, microvascular dysfunction, myocardial banding, looks like, smells like, acts like STEMI, but it's from high degree sympathetic activation, which means if your patient happens to be hypotensive and we add more catecholamines, we may actually make this situation worse. So we really want to think about these patients and remind ourselves who's at risk and how we're evaluating them. So Takotsubo disease is, as I mentioned, extraordinarily high local concentrations of catecholamines, about 30 times more. Not coronary artery disease, not microvascular disease. It's left ventricular dysfunction because of alteration of myocardial activation. Some of those myocells may actually rupture, but it's hyperactivation of the myocardial cell. And the first cause is precipitant sudden unexpected neurologic stress. So looking at the same, and there are many other things that we can look at here, but when we think about the same disruption of the autonomic nervous system, overstimulation of the sympathetic nervous system and dysfunction of parasympathetic, so really unbalanced high-level sympathetic function. When I come to your room, you have tachycardia, you may have hypertension, you may also have hypotension, but very often in the beginning, you may have hypertension. This is what people would call neurostorming, and a very significant disruption. Remember, sequestration of ionized calcium ions, causing a prolonged contraction of the cardiac muscle, hypercontractility. And if you already have myocardial disease or myocardial dysfunction, myocardial arrhythmogenesis, you're going to be significantly worse and hemodynamically unstable. If you have already a cold cardiac disease, and on top of that, you have this overactivation, this is really, really significant. And we need to understand it, because one of the most important things may be blocking your alpha and beta stimulation. That may be, this isn't fully vetted yet. We're still looking at lots of evidence in the context of this situation, but this may be the single most important thing that we're going to do with those patients. So classical clinical presentation for Takotsubo or neurogenic stunned myocardium. Remember, you can get neurogenic stunned myocardium or stress cardiomyopathy from subarachnoid hemorrhage, intracerebral hemorrhage, or from a stressful trigger. In the end, though, it's the overactivation of the sympathetic nervous system. It's the release of free ionized calcium for cellular uptake, hypercontraction, and diastolic dysfunction of the myocardium, which then relates to systolic dysfunction. Patient on EKG very frequently will have a prolonged QT, a hyper QT wave, or an inverted T wave, and they may have ST segment elevation. They're going to have a significant rise in their troponins, and they can have acute heart failure with an ejection fraction that drops down to 15 or 20%. I want to remind you, 30 times normal serum catecholamines, and that's the culprit across the board. If the patient does go for coronary angio, the discovery is that there's not really culprit lesion. There's nothing that we can intervene with. There's no thrombus, there's no plaque rupture, there's no plaque necessarily. Patient has blood flow. And remember, they have that preserved base of the LV, which always seems so strange, is that's really at the top of the LV, and down at the bottom of the LV, they're going to be quite dysfunctional in an apical ballooning, which is what we call Takotsubo. Okay, so really, really important to remember. The key here is the story, and really, really important to remember. Often stressful triggering event or a neurologic event. If you do not have definitive diagnosis, you're always going to get a cardiac cath, okay? But in these patients, what you're typically going to see, both in the subarachnoid hemorrhage, intracerebral hemorrhage, and Takotsubo disorder, is an absence of the coronary lesion. This is our patient. Actually, she went to our CVICU. We put her into TTM. This is day 3. So she woke up, she was awake, she was alert, she was conversant. So we basically withdrew her TTM. This is her on day 3 out of her bed. On day 5, she went home. On day 7, she came back and got an AICD, which is going to protect her in the future, because once you've had stress-induced cardiomyopathy, it's likely you're going to have it again with secondary stressful events. And if you remember this EKG, this was from the very, very, very beginning. Okay, so we can see we've got lots of spiked helmet signs, etc. This patient, this is our cardiac fellows note on this patient, patient has STE in the precordial leads, but she quickly resolved, and then she has deep T-wave inversions, most particularly hyper QT, and then inverted T actually represents cerebral process. She had a left heart cath in 2021. Remember, now we're in 2023. That's when she comes back. But she did not have angiographically significant disease at that point in time. And actually, she's had stress cardiomyopathy in the past. So the belief is now that she also, once again, has stress cardiomyopathy. In addition to that, she also had hypokalemia, so they were concerned that that might be part of the cause of her cardiac arrest. And that's not the patient we just looked at. This is one of the patients we looked at in the beginning. This is stress cardiomyopathy and ICH. So we look at all these EKGs, and we always have to consider and wonder, are these EKGs STEMI or are they something else? And remember, number one is to look at what the preceding or contextual situation is. And number two is if we diagnose subarachnoid hemorrhage, but we see that our patients have failure to thrive, they need an echocardiogram immediately, as soon as you possibly can get it. So that's what we can do. Actually, be vigilant, have a high index of suspicion, really discuss this a lot with your team, talk about the recognition of these life-threatening syndromes, and remember, neurologic findings with a marked QT prolongation, spiked Hellman syndrome, consider head CT first before cardiac cath when these criteria are met. I want to say thank you very much for all the work you do every single day. I'm really happy that you were able to join today on today's Tuesday topics, the heart and brain crosstalk connection. Is it adrenergic activation, which is the current theory for all of these patients today? Thank you, and I hope to see you again tomorrow. Thank you. Bye-bye.